Let's turn now and talk about really a pivotal topic that's emerged as one of the most important, if not the most important prognostic factor, and that's testing for minimal residual disease. Some people say measurable residual disease, but I'd like to turn to Aaron and ask you to talk about a little bit about the importance of this and then some of the nuances and issues that we're facing, particularly in the adult population and how we utilize this tool.
Sure. Well, as you mentioned, MRD has long been conceived as signifying minimal residual disease, and this was originally built into several children's oncology group studies at particular milestones during the course of induction and consolidation therapy. And then not long thereafter, the European groups started incorporating MRD even into the care of adult patients with ALL. So we in the United States who do adult medicine have learned an awful lot from both our pediatric colleagues worldwide as well as our adult colleagues in Europe. And as the technologies have evolved, what we're simply doing is deepening our knowledge about the patient's response to initial therapy. And so MRD really should probably be, should signify measurable residual disease. We're just simply changing the dynamic range of our knowledge. We used to define a complete remission as there being less than 5% blasts. Not a single person at this table is happy if our patient has 3% blasts at week 16 of therapy. And so with these technologies like multi-parameter flow cytometry, allele-specific oligonucleotide PCR, the next-gen sequencing approach, we can deepen our knowledge about how that patient is responding to their therapy. Have they gotten to a point where there are less than 10 to the minus 4 leukemia cells? That's one leukemia cell out of 10,000 cells in the bone marrow, which has been recognized now through various COG studies as well as the European studies, as we can discuss, as an important threshold to achieve, because that's very prognostic for whether a patient is going to relapse. And we can debate what's the right time point. Is it end of induction? Is it week 16? I would say it's all of them, and we learned this from one of the German multi-center ALL group studies where they looked at MRD at every single point of therapy on their BFM backbone, at day 11, day 24, and at subsequent time points as patients receive consolidation chemotherapy. And at every single time point, the presence of MRD greater than 10 to the minus 4 remains prognostic. And so what the regulatory, or I should say the advisory agencies such as the NCCN and the European equivalent have done is in the guidelines it now states that MRD is the most important prognostic feature that we can assess in a patient who has received therapy for ALL. And both of those guidelines now recommend that every patient who, regardless of their age, have an MRD assessment of some point. Now, fortunately, the availability of MRD assessment has caught up to the point where every physician who takes care of an ALL patient has one or more mechanisms by which they can assess disease, and I think that's very important to do.
Bijal, how should we assess MRD?
That's a great question. You brought up the cutoff of 10 to the minus 4, which has really been our basement with multi-parameter flow cytometry. But it's becoming clear, at least based on the UK ALL data, but also our experience in treating Philadelphia-positive leukemia, when we get deeper than that, it is still prognostically relevant. And so as we start to develop these molecular techniques, you mentioned next-generation sequencing, allele-specific PCR, and so on. As we start to develop these techniques, it's going to be critical that we apply them in the same way that the COG did. I think we're going to have to begin to start looking this at multiple time points through their chemotherapy regimen. So if we have that high-risk patient with early T precursor who's MRD positive at week 4, what can we expect because we are changing our therapies as we move to the consolidation phase. What can we expect after consolidation? What can we expect after interim maintenance and so on and so forth? And I think we have to have that understanding. Right now we don't, and so that's why we get a lot of guesswork. Is induction important? Is consolidation is important? Is it 10 to the minus 5? What about 10 to the minus 6? How confident can we be that that's a real value? These are all things that we critically need in the context of clinical trials, of alliance, again, the alliance-type cooperative group studies.